Hello everyone, this is Brainless Medico and I am Dr. Manoj, and today we are going to learn an important topic under rheumatology, that is polymyositis. So let's dig into it. Polymyositis. So in the name only you can understand, poly means multiple, myo means muscle, itis means inflammation. Multiple muscle inflammation will take place. So definition goes like this: polymyositis is a primary inflammatory disease. So as generally we learn in medicine, we'll first go to epidemiology, then pathogenesis, then coming to clinical features, then we'll go with the investigations, then at last how to manage the condition. So let's learn it easily. In epidemiology, we'll look into age, which is usually seen in 20 to 30 years between. Then it is slightly female preponderance. Then coming to pathogenesis, CD8 plus T cells mediated targets muscle fiber, which leads to endomysial inflammation leading to multi-organ damage. Then at last it goes to muscle fiber necrosis. Why I am stressing this endomysial inflammation, multi-organ damage and muscle fiber necrosis is you'll come to know in the investigation part. Then coming to contrast, there are many DDs for this myositis syndrome. So in that mainly we'll look into polymyositis in this video, and other video we are going to see dermatomyositis, and one more is IBM. We'll look into individual diseases in the separate video. So what is the point of taking this is, like in polymyositis mainly CD8 cells will be involved, whereas in dermatomyositis, which is one of the myositis syndrome, in that disease, in that condition, you are going to see CD4 plus complement system will be involved. So there is no confusion, I guess. Dermatomyositis, you can find a separate video in this playlist. Okay. Then coming to clinical features, first we will look into major condition, muscle involvement. Progressive proximal muscle contractions will be seen. Example, shoulder girdle and hip girdle will be involved mainly. Then coming to what are the difficulties the person is going to undergo if he gets polymyositis is like climbing stairs will be difficult for him. Then getting up from a chair, lifting arms. So after these examples, you come to know that where is the exact involvement of the site is, like shoulder or the hip. To climb or to get up from the chair, to lift arms, mainly it includes shoulder or hip joint. Then coming to systemic features, we see myalgia, which is a synonym of body pain, okay, muscle pain mainly. It may be present or absent. Then dysphagia is like difficulty in swallowing. Then dyspnea. Then you need to remember there will be no sensory loss. Since muscles are involved, people feel that it is going to involve the sensory thing and motor thing. Only motor thing will be involved, no sensory loss will be seen. Reflex is usually preserved initially. Then coming to systemic features, interstitial lung diseases will be seen, ILDs. Then cardiac, rarely we will find these cardiac symptoms or signs. Then it will be arrhythmia or cardiomyopathy, which is extremely rare, and increased malignancy risk. In myositis, polymyositis has the highest malignancy risk. You need to remember that. Coming to investigations, we look into various modalities. First, we look into blood investigations, where CPK, creatine phosphokinase, will be increased most specifically. This is the most specific among all. Then coming to LDH will be increased, ALT, AST will be increased. You remember blood investigation, things, everything will be increased. You need to remember specifically CPK, which is increased. Then autoantibodies, anti-Jo will be present, and anti-MI2 least commonly it may be seen. Then EMG, electromyography, you know, right? EMG means electromyography. Like ECG we have for heart, EEG for brain, like that for muscles we have EEG. Myopathic pattern, I said now you need to remember like in pathogenesis I said you need to remember endomysial inflammation, then muscle fiber necrosis, because these will be seen in the gold standard muscle biopsy. It is the gold standard. Rarely we do the biopsy because gold standards we usually won't prefer. We do general investigation. We can like diagnose with that general investigations only. If we come to gold standard, muscle biopsy will be the gold standard for polymyositis. We'll see endomysial inflammation, then muscle fiber necrosis. Then coming to treatment, we'll go with the stepwise management. First line, we'll go with the high dose corticosteroids. Prednisone, an example, 1 mg per kg per day we'll go. Then steroid sparing agents like azathioprine, methotrexate, mofetil, right? If you don't know the mofetil story, you can go and watch my SLE video, mofetil, which is mycophenolate, mofetil. Then coming to refractory cases, immunoglobulins or rituximab. And one of the most common question in Vivas or entrance exams they ask is differential diagnosis. So we'll first look into conditions. What are the key features which resembles the polymyositis? In dermatomyositis, skin rashes will be involved, whereas in polymyositis there will be no skin involvement. You need to remember this, very specific. Then inclusion body myositis, distal weakness will be seen, whereas Here it will be proximal weakness. Muscular dystrophy, it will be childhood onset, but whereas this polymyositis, it will be around 20 to 30 years. Myasthenia gravis, fatigability, normal CPK, whereas CPK increases in polymyositis. Then coming to hypothyroid myopathy, TSH increases, whereas it is normal, almost normal here. So what is the point of adding this table column in this video is like, when you see a MCQ, what are the key features you are going to see the differential with the polymyositis. Opposite to that, or it may not be present in this polymyositis. So in this lecture, we learnt about important topic in rheumatology, that is polymyositis. So definition we learnt, it's a primary inflammatory disease. Then coming to epidemiology, 20 to 30 years, female preponderance. Pathogenesis, we saw endomysial inflammation, multi-organ damage will be seen, which leads to muscle fiber necrosis. Then coming to contrast, we saw polymyositis, CD8 will be involved, dermatomyositis, CD4 plus complement will be involved. Clinical features, we saw muscle involvement, which will be proximal, you need to remember. And we have the another DD, which involves the distal muscle contraction. Then coming to shoulder girdle and hip will be involved most commonly. Systemic features, myalgia, dysphagia, dyspnea. Then coming to no sensory loss will be involved. You need to remember this important point. Then coming to systemic features, interstitial lung disease, cardiac, rarely we'll see, in that most commonly arrhythmia, and extremely rare we'll see cardiomyopathy and increased malignant risk. Then coming to investigations, we saw blood investigations in that modalities. CPK, LDH, LTAST will be increased, and CPK is the most specific. Then coming to autoantibodies, anti-Jo will be present most commonly. Then EMG, myopathic pattern. Then coming to gold standard, muscle biopsy, as like we discussed this in pathophysiology. Then treatment, stepwise management, high dose corticosteroids, example 1 mg per kg prednisolone. Then coming to steroid sparing agents, azathioprine, methotrexate, mycophenolate, mofetil. Then coming to refractory cases, we'll give IV immunoglobulin, rituximab. Then coming to differential diagnosis. This is not for the theory exams, but you can remember, if you write, you'll fetch the more marks. Yeah, I hope you people enjoyed the video. That's all for this video. Subscribe for more videos. Thank you.